Good afternoon. It gives me a pleasure to welcome today Dr. Thomas Link to discuss his paper, which will be published in August issue of Radiology and entitled Subjects Losing Weight Over 48 Months Showed Significantly Lower Cartilage Degeneration as Assessed on MRI and showing lower rates of progression with greater weight loss. So Dr. Thomas Link is a professor of radiology and MSK chief section at University of California, San Francisco, or UCSF. So Thomas, welcome to Radiology Podcast.
Thank you.
And my first question would be, can you explain what prompted you to conduct this study?
All right. Thanks. First of all, I would like to thank you and the RSNA for inviting me to do this podcast. I'm quite thrilled to talk about our study, and I feel really deeply about osteoarthritis and obesity. I mean, you're an expert in osteoarthritis yourself, so I'm now trying to provide a little bit of background for our audience. And one of the most key things in osteoarthritis is that we have not identified drugs which will really protect the joint, which will really in fact build up cartilage. So we are now really focused on trying to find ways to stop and prevent cartilage. We do not have good medications to really, and this is really one of the keys why we have to work on modifications of lifestyle. And one of the key modifications is weight loss and also exercise. And this is why my research over the last 10 years or so has really focused a lot about identifying how obesity, how weight loss can affect cartilage and osteoarthritis.
Thank you for that. We are in the same page. So can you explain in more detail, Thomas, what are the findings there and why they are important?
Okay, great. Happy to do this. So we are using a very well-established database here, which is the Osteoarthritis Initiative database, probably one of the most unique databases we have for studies like that, because it really looks at patients over a period of 8 years and looks at MR structural changes over 8 years. What we did was we looked at patients that were either obese or overweight, and we checked whether they would progress over time. And we differentiated them in two cohorts. We had one cohort which was a no change cohort, which was a stable cohort, and we had one cohort which was losing weight. So we had loss of weight of more than 5%. It was defined, but it was also in two groups of 5 to 10% and more than 10%. And our goal was really to see over time how this would change.
So listen, I want to just go to my third question, which I do think it's important, and you alluded to, which is in the era of, where there is no disease-modifying osteoarthritis drug, or what we call DMOD, maybe this is the way to go. I would say between hyphen, be fit as much as you can. Is that right? Is this what you are actually stating in the paper?
Yeah, I think this is, I think weight loss is critical and it's very important. In this paper, we did not look at weight loss regimes. I mean, clearly there are different ways to lose weight, and there's diet, there's exercise, there's combined. We do have, in our next projects, we actually looked specifically using a questionnaire, how did you achieve the weight loss? Was it diet or was it exercise? But this is something we haven't looked at. We have looked long-term at the impact of exercise on the knee joint, which showed that that patients that do have exercise, that perform exercise at a moderate level, have the best outcome in terms of preserving their joint morphology, while those that are not doing anything have really progression of cartilage degenerative disease over time, and those that do very aggressive sports do have also cartilage. So the best way is in the middle.
Okay, so I mean, in another word, maybe you have this, maybe not. Do you have actually any magic number that someone should hit in losing weight to start having benefit and no progression, or do you have that number?
Yeah, the more the better, of course, but on the other hand, Well, we don't know about bariatric surgery yet. That's something we have to find out. But in our study, which did not use just use normal ways to lose weight, not surgical ways to lose weight, we found that more than 10% was really giving the best results. We also saw improvements in the group that had 5 to 10% weight loss, but we saw better results in the group that lost more than 10% of BMI over a period of 4 years.
And so what do you think the role of exercise then, can it actually also help, or it's just diet, exercise, or both of them together, or one or the other? What do you think here?
That's an excellent question. So what we've seen in the preliminary data we have is that those that do both exercise and diet, they seem to profit most, while those that only do exercise to lose weight do not seem to have the best results, seem to have actually not have as great results compared to the group who does both.
Okay, I have another difficult question before going back actually to some, I would say, science. But is it known how overweight you can be, or I can be, without increasing my risk for OA progression? So we know actually maybe the number, it's being BMI, less than 25 is good. And as you said yourself, lower is better. But do we know the other way around? How much I can be overweight without actually having a risk for progression?
That's a very good question. We didn't look at this question in detail. That's probably something really important to look at. But I think it seems like we see the worst results when patients actually have more overweight. The more overweight, the worse the results are. So I think it also, sometimes it's hard to say. Some people are very muscular and have higher BMI, and some are just, so it's a little hard to really nail this down, but this is something I think, good suggestion. We're going to look at this.
Sure. My next question is about, the paper radiology issue, a September issue in 2009. Romer et al. Showed the strongest predictors of, fast cartilage loss. Among them was high BMI. Did you try to find out if this is also the case for your cohort?
Yeah, we did not look at, this was a study which looked at cartilage volume, correct?
No, it was actually semi-quantitative with most for 30 months, yes, in 2009. So we showed actually that cartilage meniscal extrusion is amongst actually one of the risk factor, also the BML as well. But from the perspective of the same actually way you looked at the data is the BMI, the high BMI, the higher BMI, the higher risk for cartilage loss in 30 months.
Yeah, I think I agree that. So I think that obesity really has a significant impact on the progression of disease, and also weight gain has an even worse impact at increasing degeneration of the joint. And I think that the point you're making, and which is really important, is also that the meniscus are interestingly specifically affected.
Okay, I have actually maybe a long question right now, but I really need your opinion here because it looks like it's looking a little bit at your study right now and also what you are doing in the future, if I understand you well. So my question is, it's going to be about the IDEA trial, which is the intensive diet and exercise for arthritis, called, as I said, IDEA trial. This is, as you know, a prospective, single-blind, randomized controlled trial that enrolled 454 overweight and obese patients. And with that, they have pain and they have radiographic evidence of tibiofemoral osteoarthritis. So the participants were randomized to one of the three 18-month intervention. One is diet-induced weight loss only. The second one is diet-induced weight loss and exercise. And then the third group was exercise only as a control. And in this study published in JAMA, Hunter et al. In 2015 showed put an effect on weight loss and on symptom as well as mechanistic outcome in this study. But on the other hand, there was no statistically significant difference between the 3 active interventions on the rate of structural progression, either on X-ray or MRI for actually those 18 months. So what is your comment here?
Yeah, this is a very important and very ambitious study which they performed. I think one of the important findings is that it takes a long time for findings to show up. So if you perform a study over a period of 12 and 18 months, the findings you will actually see the intervention specifically because it's not a super effective intervention. It's an intervention which is a lifestyle modification. But I do believe that the time period which was used, the 18 month, may have been too short. I mean, it showed clearly improvements in symptoms, which is something incredibly important to show. But what I'm worried about is that there may not be enough time to really see effective changes of the cartilage and meniscus. And it also probably depends on, and Ali, you're the expert on this, it also depends on the quality of the MRI. And I don't recall what kind of MRI was that?
It was 1.5 Tesla MRIs there. It was good. I do fully agree with you that the 18 months was a short time around for probably some structural change. I absolutely fully agree with you. And I do think, yes, as you said, that symptoms, they show better, outcome for symptoms and mechanic, but it's not really the case usually for, a structure. And that's what we see for also the clinical trial at this point. So I got your point. And I wanted actually to really finish because we summarized the whole thing and we talk about its structure and cartilage and, you've done it the absolute, right way with the full expertise that it's yours. But I want to just, my last question would be a little bit like a provocative, because we know today that the FDA will not accept a D mode or even what we call today D modes, being actually the D being drug and T being therapy, because they accept anything. If it's drug or therapy, absolutely fine with that. But they wanted actually a trial to show structural modification or benefit, but also symptoms benefit. If we don't have both, the FDA will not look at actually any D mode or D mode. So from your study perspective, I saw actually, of course, the structural benefit, but do you have also some symptoms benefit in the study as well?
Yeah, we haven't looked at, in this study, we haven't looked at this in detail. I know pain is also really an important outcome. And I mean, there are WOMAC pain scores. Now, what I'm a little worried about, however, is that we all know that pain is very variable and that patients sometimes have a very, very different idea how the pain looks like or what they identify as pain. So it's so it's not a very objective marker, and though the FDA really requires it, it's not a very objective marker for a study outcome. I personally believe that structural outcomes are more objective, and that you get better detail, you will have a better and more clear idea what's actually happening to the joint and the cartilage.
Yeah, I mean, again, we know that WOMAC is not actually really objective, and SF-36 and all what we know as, pain and functions are most of the time variable from one patient to another. And I thank you very much for that. Thanks for your time. I really enjoyed talking to you, and I hope that our readership will do so. Thanks again, Professor Link from UCSF, and hope actually again that the readership will find this paper, as I found it, very exciting and very, provocative from the perspective of, the osteoarthritis progression in overweight patients. Thanks so much.
Thanks very much for having me.